Reminder that you must have a registered Haque account. This afternoon, we'll be discussing gastroenterological and hepatic manifestations of COVID-19. We'll be recording the session, and it will post later on the Physician Resources page of UNC Health. And our speakers for today's presentation are Dr. Jain, who's Professor of Medicine with UNC School Division of Gastroenterology and Hepatology and the UNC Multidisciplinary IBD Center, and Dr. Haque with UNC Rex Digestive Healthcare. So I'll go ahead and turn it over to you, Dr. Jain.
All right, thank you. Thanks for the introduction, Lisa. I'm excited to be doing this talk for everyone today and presenting with Dr. Haque, who I know very well. I'm going to take the first half of the talk where I'll be focusing on the gastroenterological manifestations, and then Dr. Haque will jump in the second half, focusing on the hepatic manifestations. And he is also a trained hepatologist, so he's definitely the expert to talk about that. And we look forward to hearing your questions at the end. We'll try to tackle them all at the end. Next slide. I have no relevant disclosures or conflicts of interest. A quick disclaimer, however, as you all know, this is a very rapidly changing area. There's new data coming out every week. I picked up my new edition of Gastro from yesterday, and there's new articles on this topic. So the information here will probably be out of date very, very quickly. Definitely by the end of the month, there'll be new stuff coming out. Next slide. So the first question you might be wondering is, why are we here? Why did we let the GI doctors get away from the poop and come to a talk at noon? So this is a pulmonary disease. We're not infectious disease experts, but we do have a role in COVID-19. Next. So I thought I would start with an interesting case presentation. Next. So this was an interesting case, not seen here at UNC, but presented in one of the large GI journals in early April. And this was an interesting case of a 71-year-old female who had a travel history of Egypt. She spent a couple weeks in Egypt on a vacation tour in March, came back to the US, and then presented with, about 10 days after her travel, started having abdominal pain, bloody diarrhea, nausea, was feeling quite poorly, and was admitted to her local hospital. If I had been seeing this patient in my clinic or in the hospital here, I would be worried, 70-year-old with bloody diarrhea and abdominal pain. I'd be worried maybe about ischemic colitis, perhaps rarely Crohn's disease or ulcerative colitis, certainly infectious colitis like E. coli or salmonella, and I'd probably admit her and work her up for those things. Next. So that's what they did. She had a colonoscopy at the local hospital, and she had a CT scan. Her admission CT scan looks quite remarkable. If you look between those two yellow arrows on the CT, you can see that the transverse colon is very thickened, inflamed. There's that gray stranding around the colon. It's kind of hyperemic. So that is a very inflamed, angry-looking transverse colon. If you look at the colonoscopy pictures above, a little bit less dramatic, but you can see those clear red kind of splotchy areas of inflammation and perhaps a pale edematous colon. So this patient definitely has something going on. They were working her up. They were not sure what was going on. Next, please. And interestingly, 5 days into her admission, which was well over a week or 10 days after the onset of GI symptoms, she developed a cough. And this prompted a COVID-19 test, which was positive. So she had a prolonged course of quite intense GI symptoms before she developed any pulmonary symptoms. 12 days into her admission, which was a long time after the onset of GI symptoms, she actually developed desaturation requiring a high amount of supplemental oxygen. The patient was eventually discharged home and did well. Next slide. But hopefully I've convinced you that GI involvement is possible with COVID-19, and we'll sort of go through that a little bit today. So learning objectives from my section of the talk, number one, to understand the frequency of GI manifestations. Number two, understand the mechanistic basis for the GI manifestations. Number three, understand the current knowledge of potential fecal spread of the virus. Number four, talk about some recent emerging data on PPI use in COVID-19. And then number five, understand the impact on a special population, which is patients with inflammatory bowel disease. Next slide. So the way we've organized the talk is kind of around some common maybe questions that may come up. And what we tried to do is present some questions that may come to mind and then talk about a little bit of the data and current understanding of them. So first we'll talk about how common GI symptoms are. This report here was one of the earlier reports that came out. As we know, China was several months ahead of us in the curve in terms of when the virus hit them. So this was an initial report from the Hubei province in China. Next, please. And what they found is they studied in their hospital about 200 patients who had COVID-19, and they asked detailed symptom questionnaires. About 19% of their population in this cohort had some GI manifestations, with 17% having diarrhea and a small number having vomiting and abdominal pain. I separated out anorexia. It's kind of a little bit, ambiguous whether you include that as a true GI symptom or not. Anorexia can be a little bit systemic. But if you include anorexia or classical GI symptoms, about half of patients had either a typical GI symptom or anorexia. So this does seem to be relatively common. Next. Next, please. And interestingly, a very small percentage of patients, but a small percentage indeed, 3% did have isolated GI symptoms with no pulmonary involvement. So this was kind of an interesting thing that came out of this study as well. So based on this initial report, GI symptoms started to get onto our radar as a possible manifestation of COVID-19. And then the question is, what's happening around the world since the virus has moved to other parts of the world? Next slide, please. So this slide here is kind of a summary of some of the reports that have come out in the last couple of months from some large centers in the US. All of this data was published around May or early June, I believe. So these cohorts are already a couple of months out of date. However, from what we know, or what we're seeing in the California Stanford experience, about a third of their patients had GI symptoms and 11% had diarrhea. In Boston, from Brigham, a very large number, 60% had some GI symptoms, and over a third had diarrhea. And New York at Columbia, they also reported a third of patients with GI symptoms and 18% with diarrhea. Two interesting things that popped out is in Stanford, they had a decent number of patients with abdominal pain. And at the Brigham, they had 14% who started with GI symptoms as their initial presentation, although many of them may have developed pulmonary symptoms later on. They did not clarify in the report. Next slide. So there's been a number of reports. I highlighted a couple of the US ones and the initial report from China. However, there's been a number of studies, many of them from East Asia and China, but also in Europe and other parts of the world. So we've kind of pooled the data together. There was a good review in the Lancet Gastroenterology and also a recent sort of meta-analysis in the Gastroenterology journal. And if we look at all the data together, it appears that diarrhea occurs in about 8% of patients with COVID-19, nausea, vomiting, and something like 7%, and abdominal pain in maybe 3 to 4%. I separated out loss of appetite. Again, you can debate whether that's a true GI symptom or not, but about 20% of patients had loss of appetite. If you look at the first three classic GI symptoms, at least 20% of patients had GI symptoms with COVID-19. Another interesting trend, if you break out the data by region, it seems like all the reports from China are reporting lower rates of GI symptoms. So the ranges I've put in parentheses on the slide, most of the reports from China were on the low end of that range, and most of the reports from Italy, Europe, and the US have been on the high end of that range. I don't totally understand the reason for that discrepancy. It may be that there's different behavior there. It may be that there's different reporting of the way they report symptoms there. Regardless, I think that the numbers in the US are probably on the higher end of what I've cited in those ranges. So probably at least 20% and probably higher of our patients have GI manifestations with COVID-19. Next slide, please. So to that point, the CDC next has placed nausea, vomiting, and diarrhea on their list of official symptoms with COVID-19. This is a screen capture from the CDC's list of official symptoms. So this is on their list of symptoms, and they have a kind of neat little interactive symptom tracker that tries to give people guidance, and this is one of the symptoms on there. Next slide. So we've talked about how common GI symptoms are with COVID-19. So you may wonder, what do you do with a patient? So I've made up a theoretical case example. Let's say you have a otherwise healthy middle-aged patient who comes to see you in your clinic, and the patient has new onset diarrhea. What should you do? Should you be worried about COVID-19 during the pandemic? Do you send that patient for a COVID swab to your respiratory testing center? So I think this is a good question. Next, please. So if we review the data that I've kind of presented and just focus on that question, the initial report from China had 3% with isolated GI symptoms. The report from Stanford explicitly commented that none of their patients had isolated GI symptoms. And the report from Boston stated that 14% had initial GI symptoms, but many of those patients may have also had respiratory symptoms. So not as clear of an answer from that study. The Boston study also reported that a large percentage of their patients with GI symptoms did have loss of smell or taste. So that may be an interesting kind of tip that those symptoms may go along with GI symptoms. So if we put that together, next point, please. My clinical take home is that if you have somebody with new onset GI symptoms in our current pandemic world, I would stop and take a careful history. I've had this come up a couple of times in my practice. And what I would do is I would ask very closely about other concomitant respiratory symptoms, other systemic symptoms. I would also ask about loss of smell or taste. I'll say that 2 patients, GI patients that I've seen with COVID-19, their initial symptoms was actually loss of smell. So I would ask about those, loss of smell or taste, and ask about any high-risk exposures. My current interpretation of what we know is a patient with new onset of diarrhea, nausea, GI symptoms with no high-risk COVID exposures, no other concomitant symptoms, no systemic symptoms. I think the likelihood of COVID-19 in that situation is pretty low. And I don't think you need to send every patient with new diarrhea for a COVID swab immediately. I would probably look for other etiologies. However, if they have loss of smell or taste, if they have cough, shortness of breath, fevers, or a high-risk exposure, I probably would go ahead and test them for COVID-19. And that would sort of be my interpretation of our current knowledge. Next slide, please. So the question I posed for this section is, how common are GI symptoms with COVID-19? My answer is that they're fairly common. At least 20% and perhaps more of patients will have GI symptoms with COVID-19, and a very small percentage will have isolated GI symptoms. So it's rare, but it is possible. Next slide. The next question that I wanted to tackle is, do GI symptoms predict worsened outcomes? So we've kind of established that GI symptoms are reasonably common. So the next extension might be to ask if GI symptoms actually portend a better or worse prognosis with COVID-19. And we do actually have some emerging data on this. Next slide. So rather than go through every study, I'm going to sort of summarize the data through the Lancet Gastroenterology review. They did a meta-analysis of the current data that's out there. There was also a similar study from Stanford's experience published in one of the GI journals, the Red Journal, that showed a multivariable regression analysis and came to the same conclusion. So it looks like patients who have GI symptoms with their COVID have a higher rate of severe or critical COVID-19 with an odds ratio of close to 4. And patients with the GI symptoms appear to have a higher rate of ARDS with an odds ratio of almost 3. Interestingly, in that same sort of review, there was not an increased rate of hospital stay or mortality in patients with GI symptoms. So a little bit of a mixed signal, but there does seem to be a trend that perhaps patients with GI symptoms do worse with their COVID-19. Next slide. Here is the actual forest plot data from that meta-analysis, and the point is not to go through all of this in detail, but what I wanted to show is they didn't just look at GI symptoms lumped together. They actually looked at the risk of severe COVID-19 broken out by different symptoms. So at the top, you have loss of appetite. In the middle, you have diarrhea, nausea, vomiting, and abdominal pain. And where that red arrow is going, you see that the strongest signal appears to be patients who have abdominal pain seem to have the most clear trend for worsened COVID-19 outcomes, whereas the other symptoms like diarrhea and nausea are kind of equivocal. So my interpretation of this would be, if you have a patient with COVID-19 who has GI symptoms, particularly abdominal pain, I would maybe be a little bit more worried about that patient and keep a little closer eye on that. So that would be the group that concerns me. Next slide. As a reminder, if we look at the data I showed you earlier, amongst GI manifestations, the smallest percentage appears to be abdominal pain. So it seems like relatively few patients have abdominal pain, but it may be that if the patient has COVID and is developing abdominal pain, that might be the group of patients who really has bad disease. And that may be a marker of just more intense burden of COVID-19 in that patient. Next slide. So do GI symptoms predict worsened outcomes with COVID-19? I think the data on this is still thin and emerging, but from the data we have right now, I would say it looks like, yes, they do. And in particular, abdominal pain may predict a worsened outcome with COVID-19. Next slide. So hopefully I've convinced you in the last 15 minutes that GI manifestations are relatively common. There may even be some signal that patients with GI manifestations do worse. So if the virus is getting into the GI tract and causing problems, we may wonder, well, is it actually found in the stool? Is the virus getting out of the stool? And is there the possibility of fecal transmission? Next slide. So I wanted to spend a couple of minutes talking about the sort of basis for GI involvement with COVID-19 and how that may have implications for route of viral spread. As I think we're all familiar by now, the COVID-19 virus, or SARS-CoV-2, it gets into host cells through the ACE2 receptor. The graph shown on this slide shows the relative expression of the ACE2 receptor in different organs. And you can see in the middle of the slide with that arrow is lung expression of ACE2. So there's a reasonable amount of lung expression. And if you go way out to the left, actually the colon appears to have very high expression of ACE2, apparently even higher than the lung. So ACE2 is found in multiple organs, including the GI tract, which may be part of the basis for GI involvement. Next slide. However, the story is not quite that simple. There's a little bit more going on. It actually appears that the virus needs expression of not just ACE2, but really uses a protease called TMP-RSS2, and co-expression of ACE2 and this TMP-RSS2 protease is really what's needed for effective viral entry or invasion into the cell. And there's a schematic of that shown in this little diagram on the slide, and it's showing an example of the enterocytes that are expressing ACE2 and TMP-RSS2. Co-expression of both of these receptors occurs in the alveoli, hence the pulmonary involvement, but also appears to occur in significant levels in the small intestinal epithelial cells, which is why we think the virus can actually get into the GI tract and cause GI involvement. Now, at first, my assumption was the virus gets into the intestinal cells, it damages enterocytes, causes direct toxicity to the GI lining, and hence you get sort of this inflammatory diarrhea. The proposed pathogenesis is a little bit different and is shown on this slide. Again, this is somewhat speculative, but this is the proposed pathogenesis. It seems like the virus gets into the enterocytes. It then affects intracellular signaling, and it affects the release of various amino acids from the cells into the lumen of the GI tract. The amino acid composition in the lumen of the gut affects the bacterial composition, and it's thought that basically the virus invades the GI cells, affects the amino acids, dysregulates the bacteria, and that's why you get diarrhea and nausea and vomiting. That's the proposed pathogenesis. Okay, next slide. So if the virus is able to get into enterocytes, then we will probably wonder, can the virus actually be spread in the stool, which is kind of a scary proposition. If we think about kind of a theoretical model of fecal spread of any virus, there's three potential routes how a virus could be spread through a fecal mechanism. Number one is direct fecal oral spread. This would be, your classic example would be like norovirus or hepatitis A, which have direct fecal oral spread, direct virus in the stool that somehow gets into a person's mucous membranes and gets ingested. Route number two would actually be that there's virus in the stool, and then there's that somehow gets aerosolized in droplet form. And then number three would be sort of the direct fomite or surface contact. This would be, stool contaminating the toilet seat or the door handle or the toilet flush knob. So those are kind of potential routes of spread. Next slide. And there's been a lot of media reports of this. Your patients may even ask you about this. So here's two just snippets of articles online, one from the Washington Post and one from Forbes, basically raising the concern that the virus could be spread through flushing the toilet bowl, and we have to be careful about flushing. Next slide. So where this came from, these reports of toilet spread of the virus all came on in June. And if you see, I've cited this article published in a physics journal that I'm not familiar with called Physics of Fluids. And it was published on June 16th. And right after that, within days after that, there was all these media reports of possible toilet spread. Unlike some of you, I do not read a lot of physics journals, so this was all new jargon for me. Apparently, physics journals are very different than medical journals. So the paper was filled with interesting equations like this and like this. And there was no actual virus involved here. This was a purely physics modeling study, so no virus was harmed in the making of this research study. What they did is they model like the fluid dynamics of a toilet. So they had these kind of nice little fluid dynamic graphs. Next, please. And then they made these really pretty kind of graphs and pictures showing how the water flushes, and they put example small particles in the water and tried to trace how the particles moved during a flush. And what they came up with through their equations and modeling was this. And what's shown on the bottom two graphs there, the ones with the rainbow colors, is the little line, and I know this is hard to see, that says Y0 is the top of the toilet bowl. And if you see the green, yellow, and orange red particles that are above that are a kind of model of theoretical viral particles floating up as the toilet is flushed. So they actually flushed a toilet or multiple toilets, put model particles in them and measured how high they went. And what they concluded, next please, is that viral particles theoretically could spread up to 3 feet above the toilet bowl and could linger in the air for up to a minute after you flush the toilet. Again, this was not real virus. They didn't actually measure virus. They just modeled it. And their conclusions from the study was you should close the toilet seat before you flush. You should wash your hands and perhaps even cover the toilet seat. I don't know how practical this is. And again, this is not real viral spread, but this is out there. And this particular article got a lot of attention and got a lot of media coverage. So you may be hearing this. Next slide. So I'll move on from physics studies to actually talking a little bit about what we actually know about the virus and try to put this in some context and give you some idea of how much we should actually be worried. So I gave you the theoretical ways that we could have fecal spread of the virus, but there is actually, we have to think about other factors as well. So in order for a virus to actually be spread through a fecal route, we have to know if the virus is actually shed or released in the stool. Is this an intact live virus, or are we just measuring RNA in the stool? And if so, if there is intact virus, what is the actual viral load? If there's a negligible viral load, the risk of spread is very, very low. Next slide. So here's what we know. This is, again, some pooled data. There's been multiple reports of fecal measurement of COVID-19 virus in the stool. The available studies sort of cite that between 40 and 80% of patients will have detectable viral RNA in the stool. The pooled estimate is almost 50%. So about half of patients will have detectable RNA in their stool. However, the real rub and the real question is whether this is just naked RNA that can't cause a problem, or whether there's actually true intact viral particles that could spread the virus and cause infection. There's only 2 studies that I could find that really directly address this. The first is a small study of 9 patients who had COVID-19 and diarrhea, and they were not able to isolate any infectious viral in the stool, despite having a high viral RNA load in the stool. So these were patients who had diarrhea, had COVID-19, had high viral RNA. They could not isolate actual virus in these 9 patients. There was another study from China where they looked at 4 patients with diarrhea and fecal RNA. They reported that in 2 of those patients, they were actually able to culture, quote, live virus. What they mean by that is they actually looked with an electron microscope and they were actually able to see fully intact viral particles with the nuclear capsid there. So they were able to see intact viral particles on an electron microscope, but it is actually not clear if this virus was capable of causing an infection, and it was not clear what is the actual viral load of intact virus. Next slide. Here is an interesting kind of graph. Again, this is not exact numbers, but this shows you a schematic. This was from a JAMA article a couple of months ago about the different methods by which we could measure COVID-19. The blue line shows our typical pharyngeal swab that we're doing in practice these days. And you can see the pharyngeal swab will tend to become positive within a week before symptom onset, and will stay positive for up to a couple weeks after symptom onset, but then will gradually wane and become negative. The kind of yellow-green line there shows the measurement of stool RNA through PCR, and you can see that the stool RNA actually can persist for a very long time. Some people have suggested this may be viral replication that goes on in the gut. However, this could just be, again, sort of bare RNA and not intact virus. There was one study that reported about 1/3 of patients will have positive RNA in the stool even after the respiratory specimen is negative. So the stool RNA seems to persist for a very long time. Again, it's not clear if that is intact infectious virus. Next slide. So I thought it'd be helpful, since we have such limited data, and this is certainly an area of concern, to put this in the context of other coronaviruses that we have a little bit more experience with. So on this slide, I've shown the other kind of coronaviruses that we have better working knowledge of. The original SARS coronavirus, SARS-CoV, is shed in the stool for sure. There is no detectable live virus that's ever been found, or intact virus, and there's been no reported cases of fecal spread with the original SARS virus. With the more recent MERS, Middle Eastern respiratory virus, that virus was also shed in the stool. There were some reports of possible low viral load, but possible intact virus in the stool, but there were no reported cases of fecal spread. Next slide. With the SARS-CoV-2, I think I've shown you good data that about half of patients will have detectable virus in the stool. So there is some viral particles, RNA, are certainly shed, but whether there's actual intact virus is debatable. I showed you the 9-patient study where they could not find it, and 2 where they could see some viral particles on electron microscopy. Is there fecal spread? I think no, probably not. There's been no reported cases of clear fecal oral spread, but certainly this is something that needs to be watched out for. So that's kind of my interpretation. I think it's probably not, but we have to keep an eye on this. Next slide. So is COVID-19 found in the stool? Is there fecal transmission? I think the answer to that question is there is definitely a large percentage of patients will have detectable viral RNA shed in the stool, but whether this is actually infectious virus is unclear, and my answer to that would be probably not. Next slide. In the last couple of minutes of my section, I'm going to talk about a couple of sort of unique situations that you all may encounter in your practice or you may hear about, and we'll just cover them in turn. Next slide. So some of you may have seen this. I don't know how many people have seen this. If we're doing a live talk, I would ask for a show of hands how many people have actually seen this PPI study. This just came out 2 weeks ago, so this is pretty fresh off the presses. Next. So what we know, going back to the original SARS virus, is we know that PPIs are very effective at raising gastric pH. So on average, use of a full dose PPI will raise your gastric pH from a pH of 1 or 2 to about a pH of 6, which is close to neutral. And remembering that pH is a log scale, that equates to something like a 10,000-fold increase in the decrease in the amount of acidity in the stomach on PPI. And that decreased acidity in the stomach does increase the risk of enteric infections, such as C. difficile infection, which is established. Going back to the SARS coronavirus, there was some data with that virus that a pH greater than 3, gastric pH greater than 3, seemed to increase the risk of the SARS coronavirus. So that led to the theoretical concern that PPI use may increase the rate of SARS-CoV-2. Next. So this data just came out, again, 2 weeks ago in one of the large GI journals. This was a large population-based online survey conducted from early March to late June. They had 53,000 participants in this large US-wide population survey, and they found about 6% of the cohort reported being tested positive for COVID-19. This is by patient report. And they also had data on various medications, including PPI use. And they did a multivariable regression analysis. And what they found is that patients on once daily PPI had an odds ratio of approximately 2 for getting coronavirus. And patients on twice daily PPI had an odds ratio of about 3.7 of getting coronavirus. Interestingly, H2 blocker use did not appear to increase the risk of coronavirus. So from this data, next point, please. From this study, it appears that PPIs do seem to increase the risk of getting COVID-19, and there is a trend for a dose-dependent relationship. And when we see a relationship like this with a dose response, that makes us think that this may be a true factor, a real issue, and there's also a plausible biological basis for this. So there is reason to believe that this is a real phenomenon. Keep this in mind that this is only one study, but it is a fairly large, well-done study. And with all of the bad press that's come out with PPIs, we have to remember that we have to interpret all this data in the context of residual confounding. And what I mean by that is that patients who are on PPI may not be the same as patients who are not on PPI. They may have other comorbidities that are not fully accounted for in the data set or that cannot be controlled for on regression analysis. So it may be that patients with PPI, for example, have higher rates of obesity or smoking or other risk factors that may increase the risk of coronavirus. And it's not just the PPI, it's actually the other comorbidities that can't be measured. So we have to keep all that in mind. But from this data set, I would say it does look like PPIs increase the risk of getting coronavirus. Next point, please. So my clinical take home for this would be not to just knee-jerk yank all of your patients off their PPI. Your patients may call and ask you about this. I think the take-home message is not terribly different than what we've been saying for years, which is use caution, make sure the patient has a good reason to be on a PPI, use them judiciously, and use the lowest dose possible. If you're able to decrease a patient from BID to daily, that makes sense. If you can decrease from daily 40 milligrams to 20 milligrams, that makes sense. If the patient has very minimal symptoms, perhaps they could come off the PPI and do a trial of a drug holiday, or switch to an H2 blocker if they only have mild or intermittent symptoms, because there's not the same signal seen with H2 blockers. Next slide. The last couple of slides I have, I'm going to talk about a special population, which is patients with inflammatory bowel disease. This is near and dear to my heart because my practice is focused on patients with Crohn's and ulcerative colitis. So these are the patients that I see all day in my clinic. And a lot of our patients with Crohn's and ulcerative colitis have a lot of questions, and we've been just flooded with questions from patients about what do they do with their medications. A lot of my patients are on immune suppressing medications to treat their inflammatory bowel disease, and they want to know if they need to come off of their immune suppression because of the coronavirus. There, again, is data that's starting to come out. We're starting to get some decent guidance from the existing data. What I've highlighted on this slide is a large registry called the Secure IBD Registry. Dr. Haque will be talking about an analogous study in liver patients. And what we see is this is a large international registry. It's actually being jointly run by some investigators, my colleagues here at UNC, as well as a couple of investigators in New York at Mount Sinai. And so far, they have about 1,800 patients in the registry with inflammatory bowel disease who developed COVID-19. They have detailed physician reports of what medications the patient was on, how their disease was doing, how their outcomes have been, et cetera. About 3/4 of the patients were on some form of immune suppression, whether that is thiopurine medications, steroids, TNFs, or other biologics. And what we've seen so far is that our patients on immune suppressing biologics do not seem to be doing worse with their coronavirus. Their outcomes seem to be very similar to the general population. And their outcomes included a composite outcome of hospitalization, ICU stay, ventilator use, or death. So from this, reasonably large data set, it looks like patients who are on immune suppression for inflammatory bowel disease are not doing worse than the general population, which is encouraging and allows me to comfortably tell my patients, please stay on your medication. I don't want you to have a flare if you stop your medications. The one signal for problems was steroid use, and it appeared that patients who were on steroids, including prednisone, did appear to have worsened outcomes with their coronavirus and had higher rates of ICU stay, hospitalization, and death. So steroid use appears to be the clear signal, and all of the other biologics and other medications appear to be safe based on what we know so far. Based on all of this, our current recommendation to patients is please do not stop your immune suppressing medications. If a patient calls you in your primary care office saying, should I stop my adalimumab, my Humira, my Remicade, infliximab, or other medications, the answer is no, please don't stop them. Certainly guide those patients to call us in the GI clinic, but the first response is do not stop your medications. In particular, we worry that if a patient stopped their medications, they could have a flare of their Crohn's or colitis and then potentially need steroids as an inductive rescue therapy, and that prednisone use may actually put them at risk of bad outcomes. Multiple GI societies have made position statements sort of in the same way. Next slide, please. The last thing I'll talk about is another thing that's near and dear to my heart. If you talk to any GI doctor, the vast majority of them did GI because they like scoping, and it's kind of a fun hands-on procedure where you can do something tangible to help your patients. So if you talk to me in March or April, I'd say we're basically just prioritizing urgent procedures and have put everything else on hold. We can't continue to delay elective procedures forever. At some point, patients are going to have problems with strictures and colon cancer. So we have been finding ways to resume endoscopy. I'll tell you the UNC experience, and I'd be interested to hear from Dr. Haque what they're doing at Rex. Next slide, please. The questions in terms of endoscopy with COVID-19, first question is, what is the risk to our patients? Are patients going to come to the endoscopy and get the virus? And the flip side to that is, what is the risk to us as nurses, doctors, and staff? Are the staff going to have high rates of infection? So there's 2 Italian studies, and I think the Italian studies have come out because they were hit really hard in February when we were still pretty naive and glib about this virus. So they were a little bit ahead of us. And there's 2 studies I'll highlight. The first one was 800 patients who they tracked for 2 weeks after endoscopic procedures and found 1 patient developed COVID-19. So risk of transmission to patients seems to be very, very low. And this was early on when they had high rates of virus and low PPE availability. Note that there was only 2 weeks of follow-up. The risk to staff, similar story, appears to be relatively safe. 4% of endoscopy staff reported being positive for COVID-19. However, we have to take that with a grain of salt. Most of those cases happened before they had good access to PPE, and the rate of staff positivity was very, very low after they had good supplies of PPE. Also, many of their endoscopy staff were deployed to the ICU, ER, and other units to help with emergency sort of disaster triage care. So next point, please. So what we're doing at UNC, I'll tell you what we're doing right now. There's a couple of things that several modifications we've made, and we've been resuming endoscopy procedures for many patients. We're up to something like 70, 80% capacity at UNC. The most important thing we're doing right now is pre-procedure testing. So any patient who needs an endoscopy or colonoscopy procedure has to have a COVID-19 test done and documented negative within 72 hours prior to their procedure. So we can feel relatively comfortable that the patients are coming in are negative. We're also being very diligent about PPE use. We're using full gown and gloves, N95 mask, and hairnets. We're extending the procedure time to allow for more time for cleaning and for less congestion in the unit. And we also have decompressed the waiting rooms by having all family members wait in the car rather than in the waiting room. So the waiting room is actually very, very sparsely populated. Next slide. Next slide, please. So a quick summary, and then I'll turn it over to Dr. Haque. What I've talked about today, the summary take-home points are that GI manifestations appear to be relatively common with COVID-19, at least 20% of patients, or perhaps higher in the US. Isolated GI symptoms are rare but possible. There is some emerging data that patients with GI symptoms may do worse with COVID-19. I think that's particularly true for patients with abdominal pain. In terms of viral spread, there are clearly high rates of viral RNA that's detectable in the stool, and this can persist for a long time, but there is no compelling evidence that there is actually infectious virus that is shed in the stool, and there has been no reported or confirmed evidence to suggest fecal spread of the virus, even though we need to keep an eye on this. I highlighted the recent large study suggesting that PPI use does appear to increase the risk of COVID-19, particularly in a dose-dependent fashion. So I would continue to be judicious about PPI use, but don't stop them reflexively. Patients with inflammatory bowel disease should not be stopping their biologics or other immune suppressing medications. Steroids would be really the most concerning thing for those patients. And we are right now resuming most endoscopy procedures, though with considerable modifications to our workflow. That's all I have, and I'll turn it over to Dr. Haque to talk about the liver manifestations.
All right, thanks, Dr. Jain. That was great. With my talk, it's going to be focused on more of the liver manifestations of COVID-19. There's a little bit less data for liver stuff, just because primarily a lot of people don't have symptoms of liver disease. It's more based on lab work, but I'll show you what we've discovered so far. Go to the next slide, please. All right, so I was going to do the same as Dr. Jain did and start off with the case. This is kind of an atypical case. This was reported early on in the pandemic in April. But I just wanted to point this out as to what has been reported, and contrasted with what we now know more about COVID-19 and the liver. So with this particular case, a 59-year-old woman had presented with just dark urine. She had a history of well-controlled HIV, was on antiretroviral therapy, didn't have any respiratory symptoms at all, no GI symptoms at all, just really presented with dark urine. Noticeably, when she presented, her lab work showed a significant transaminitis with an AST greater than ALT in the thousands. Notably, she was not jaundiced. INR was normal. Her alk phos was also relatively normal compared to her other transaminases. They checked her for acute viral hepatitis, including CMV, EBV, and RSV, which were all negative. Had an ultrasound that was normal as well, didn't show any steatosis. But then the next day is when she started developing her respiratory symptoms, where she got fever and hypoxia. Chest X-ray showed that she had bilateral infiltrates, and her NP swab came back positive for SARS-CoV-2. So you can see in this graph that her liver enzyme, or transaminases, just slowly improved throughout her hospitalization. It kind of got down to not normal, but significantly better than when she presented. And I'll get to this more later on in the talk, but the things that kind of stood out to me with this case is that the authors didn't stipulate whether or not they checked the CK in this case, which gets your antenna up and you hear if anybody presenting with dark urine and an AST that high. And then they didn't really talk about her alcohol use too, which is of course you want to get when you see a ratio of that magnitude as well. This I just wanted to point out is kind of an atypical presentation of hepatic disease with COVID-19, but we'll kind of get to more of the traditional things that we're seeing later on. You can get the next slide, please. So in terms of how this happens, so not really clear. So as Dr. Jain had alluded to, we think it has to do with the ACE2 receptors. And that slide that he showed earlier, on the far left was the colon and the intestines, but kind of towards the right side, it was definitely less than the lungs as well, but the liver was there. We tend to see that cholangiocytes express more of the ACE2 receptors than hepatocytes, and that could also be reflected by the gallbladder on that slide, showing that they had a lot more ACE2 receptor expression. But when you actually do a biopsy of someone who has COVID-19, this is the one case report that's been widely circulated that has the actual histopathology that we could reference. But this is taken from someone who had active COVID-19, had more severe respiratory symptoms, and had died from complications from it. But the biopsy in this gentleman just showed microvesicular steatosis. I can't really show you because I don't have access to the pointer, but you just see those little clear dots inside the hepatocytes, which suggest those are just fat droplets. And then some non-specific portal and lobular inflammation, just little blue cells kind of littered around the parenchyma here, which is non-specific lymphocytes. They don't show you any bile ducts in this picture, but per the case report, they did not really mention any issues with bile duct injury. So, when we're trying to extrapolate from this case report and the pathophysiology of how this is happening, when we see microvesicular steatosis, that is usually indicative of mitochondrial disease. So if there's any direct virus implications on the mitochondria, maybe that's affecting the health of the hepatocytes that way. If there's more of the ACE2 receptors in the bile ducts, is there more of a bile duct injury pattern? The other argument there is that you see more of a hepatocellular pattern with injury, not more so a elevated cholestatic process with this. So we're not exactly sure how it happens, but there's lots of theories about how it could. Can you go to the next slide, please? So in terms of what we do see, so a lot of the data has actually been out of the Chinese data. There hasn't been a whole lot published yet in the US regarding transaminases, but what we found is about a quarter to a third of patients who present usually hospitalized will have elevated liver chemistries. When you kind of pull data in terms of what has been published outside of China, and when you take into account more outpatients, then that's closer to about a fifth of patients. In terms of what you do see of how severe the transaminitis is, it's usually very mild. You'll see the AST and ALT go to maybe 2 to 3 times what's normal at most. You don't really see jaundice. If their bilirubin does get elevated, it's not usually more than about 2 or so, so it's not really severe, but it's mainly a mild transaminitis. As I mentioned, not traditionally cholestatic. There was one trial that did show that there was some mild elevation to GGT, but again, normal alkaline phosphatases. In terms of predicting severity of the disease, it has been shown that people who did have more elevated transaminases or more elevated bilirubins tended to have more severe respiratory disease, where they had higher oxygen requirements and were in increased respiratory stress. Whether that's a marker of just more severe critical illness versus it having some form of pathologic tendency towards more severe disease, unknown. But there has been reports of those who have more elevated liver enzymes having more severe respiratory disease. Again, the data is pretty limited in terms of where we're getting the sources from. A lot of this is coming from the Chinese data, where their prevalence of chronic liver disease is a little bit different than the U.S. population, where they're seeing a lot more viral hepatitis versus fatty liver disease in the U.S. A lot of these studies were done on hospitalized patients, so we don't really know what their baseline liver enzymes were. And these studies have that the majority of patients who were coming into the hospital were already on some form of antibiotic or antiviral, presumably done as an outpatient when they were starting to feel sick. So, there's certainly that question as to whether or not there could be a component of drug-induced liver injury as well. You can go to the next slide. So, the question as to whether or not does COVID cause hepatitis, from what we can tell, yes, it does, but with that same respect, it's usually very mild. So if you see, enzymes that are much higher than that 2 to 3 times upper limit of normal, definitely look for other causes, which we'll get to later on in the talk. All right, you can go to the next slide. All right, so I did want to talk a little bit more about some of the chronic liver diseases that we're seeing affected by COVID-19 as well. So going back to that first case presentation that I referenced, so with that case, AST was significantly elevated, greater than the ALT, and there's certain aspects of the liver that you certainly want to remember. And when you see that AST greater than ALT ratio, definitely remember the basics. Look for alcohol, rhabdo with cytokine storm. We are seeing more elevation in AST as well, and ischemia can also present like that as well. But to comment more on the alcohol portion of this is that with the pandemic, with the stay-at-home orders, we are seeing a lot more relapse with alcohol use, and I can personally attest to this with a lot of my patients that they are struggling to remain off alcohol. There's more encouraging of risky drinking behavior as well due to social media. There's like I think her name's the Barefoot Contessa, was showing you how to make a face face full of margarita there with alcohol. It's been reported on the New York Times and Guardian about this increased drinking during this pandemic as well. So that's definitely putting more stresses on things like transplant evaluation, where people can't maintain their sobriety before transplant or even post-transplant, or even in those who have chronic liver disease from alcohol, it's hard for them to remain off alcohol in this setting as well. You can go to the next slide. In terms of fatty liver disease, so not a whole lot of data out there, but I did want to highlight this one study that was out there in the past 2 months. This just showed that folks who had fatty liver disease, as well as being older and being heavier, just tended to have higher risk for more progressive respiratory disease during the course of their illness. That's not surprising. With fatty liver disease, they have higher comorbidities, including diabetes, high blood pressure. So you would expect them to have more severe disease as well. But the other note that this study had mentioned was that fatty liver patients tended to have longer times to clear the COVID virus as well, where it took them over 2 weeks to clear the virus versus about 12 those who did not have fatty liver. This was also the trial that did show that elevated GGTs tended to predict more severe disease. This is only one trial that showed this, but it hasn't really been borne out in others as of yet. I can go to the next slide, please. In terms of cirrhosis in COVID-19, this is kind of like a no-brainer, but obviously those who have cirrhosis tended to do more poorly when they had COVID versus those who had COVID only. This is a pretty small trial that was done, but kind of just alluded to the point where 30% of the mortality rate of those who had cirrhosis and had COVID-19 was around 30%. When you compare it to those who just had COVID, that mortality was still a bit high at 15%. So definitely higher than what's been reported. But you can see that if you have cirrhosis as a comorbidity, they tend to do worse. Interestingly enough, though, with folks who just had cirrhosis without COVID-19, the mortality was actually not that much different. But we just know that if you have cirrhosis and you get COVID, it's a bad combination. You can go to the next slide. This is the registry that actually was similar to what Dr. Jain had discussed earlier about IBD. On the flip side, in cirrhosis, this has actually been headed up by one of my mentors at UNC, Dr. Barrett. But this is a database that's been conducted around the world with a joint partnership with the European Society of Liver Disease. But basically, it's just a survey that providers can submit into this database to give the rest of us just an idea of how cirrhotics are doing throughout the world. And what you can see is that in this in the database, what's been reported that mortality is comparable to what that last study showed, where the death rates are around 30% in the cirrhotics that have been reported. Granted, this is limited by bias by what's been reported, but this would make sense is that in those who had liver disease, they have higher rates for decompensation as well as mortality if they get COVID-19. So if someone has cirrhosis, they are immunocompromised by definition. So if there's any suspicion for COVID-19, it's important to get them tested, and it's important to have early intervention to again, try to minimize the complications of decompensation and death. Next slide, please. So yes, to answer that question, yes, they have worse outcomes. Next slide. All right, briefly to touch on the drug effects that we are seeing with the new therapies for COVID-19. Remdesivir has been reported in the initial trials with compassionate use of having a fairly high record of causing elevated liver enzymes. It had to be discontinued in 2 patients. But as we did the larger trial for the randomized control trial, it actually looked like the rates of increased aminotransferases wasn't any different than placebo, really. So it may cause a little bit of elevation in liver enzymes, but it hasn't been shown to be dangerous. And the benefits of being on therapy don't outweigh the risks of being on the medicine. In terms of dexamethasone, you're on it for a short time. It doesn't really have any long-term consequences. There's that theoretical risk of reactivating inactive Hep B, but for the short time they're on dexamethasone, that risk is pretty low for reactivation. Hydroxychloroquine, I mentioned, even though it's falling out of favor, is pretty safe for the liver, as is azithromycin. You can go to the next slide. And then just to wrap up, so in terms of how to approach abnormal liver enzymes in the setting of an active COVID-19 infection, so again, you expect to see a mild elevation in the liver enzymes, again, 2 to 3 times what's normal. But if it's higher than that, it should really raise your red flags about other causes. The things I would think about are particularly drug-induced liver injury or a co-infection of another viral hepatitis. If things are getting worse, then again, look for other causes that could be causing this problem. Imaging if there's evidence of cholestasis. But the role of a biopsy in this situation has not been shown to be really helpful. I think the 2 situations I would think about doing it is if someone is post-transplant and you're wondering if they could have rejection, or if there's someone that has autoimmune hepatitis and there could be flaring. But in terms of the day-to-day management, if someone has abnormal liver enzymes with COVID-19, it's kind of par for the course. And as long as it stays in that range, and you can't think of any other causes for it, then really the role of a liver biopsy is pretty limited. All right, and I think we have 3 minutes left for questions, so that should be it.
If anyone has questions, you can go ahead and submit them into the chat feature.
I think just to touch on what Animesh had mentioned earlier with regards to endoscopy, yeah, from our standpoint, we're doing the same thing at Rex. For anybody coming to the hospital for their procedures, we are also doing preoperative testing to make sure they're negative for COVID, at least 72 hours as well. All providers are wearing PPE with N95s. In our outpatient endoscopy center, though, we are not routinely doing COVID-19 testing, but all the staff, this is really just based on the Italian data. As long as you're wearing PPE with appropriate N95s, the transmission rates are really low. So that's what we're really sticking with in our ASC, is that we're just all wearing N95s. Everybody's wearing masks. Like you mentioned, the rides are waiting in the car, not coming into the center. We're spreading out the times of our cases to allow for social distancing, but we're doing a lot of what you're doing over there at Chapel Hill too.
So I'll ask a quick question for Dr. Haque. So you talked about the high rates of LFT abnormalities, particularly from the early reports in China. China does have other issues like high rates of chronic hepatitis B,
yep.
In the population in China. Do you think that could be factoring into that, and that might be different in the U.S.?
Yeah, so they that question was raised too, but for the majority of those who had viral hepatitis, it's usually inactive, or when they've checked in those who've had viral hepatitis, they've made sure that the Hep B is under control, and there doesn't seem to be any spike or rise in their viral loads of Hep B that's contributed to this as well. And that's why I think it's going to be important when more U.S. data comes out to see if that same trend is there, to see if we have that same mild rise in transaminases. But when you had done the pooled analysis of the Chinese literature with the literature that's been outside of China, one was a U.S. study, one was a Japanese study, it was a little lower. So like it went from 30% down to like maybe 15 to 20%. So it may not be as prevalent in the West as it was in China. One question I had from what you had reported with the 3 centers, I think it was Stanford, Columbia, and I forgot what the other one was, but I'm wondering, they've been talking about how the virus in the West Coast is primarily same phenotype as the virus that was seen in China, whereas the East Coast has been more isolated to the European virus. And I wonder if there could be different phenotypes in terms of the presentation with GI symptoms between the two of them, because it looked like I think it was the Stanford data had higher rates of gastrointestinal manifestations, what I recall.
That's an interesting question. I hadn't actually thought about that. It was actually the Boston cohort, the Brigham cohort. They had 60% GI manifestations and like 35%, I think, diarrhea, which was way higher than any other report. So I hadn't thought about that, but that's a good question, that some of the discrepancies we're seeing may not just be, say, reporting, but there may actually be different viral subtypes in different regions. So that's an interesting question. And I don't know the answer to that. I don't know that anyone's done like viral genome studies to see if there's differences. That's an interesting question.
We do have a couple of questions that have come in the chat box.
Oh, great. Sure.
The first one is, saw a patient today through telehealth, a 31-year-old healthy male with acute RUQ pain, GERD, sore throat, fever 103, LFT, CBC, lipase, normal, RUQ ultrasound normal, COVID pending, no obvious exposures or risk, no other GI symptoms. Do you think this would be a COVID positive?
So yeah, okay, there it is. I just saw the question. Yeah. So my take on it would be, this patient, my suspicion for COVID here, if he had no high risk exposures, I mean, it sounds like there's already a COVID test pending, but my guess is probably not. I mean, Sore throat, fever, that's a tough one. Sore throat, fever, I think that's a tough call. I would not, if I had to bet, I would not bet that that patient's COVID test is going to be positive, but could I be wrong? Absolutely. If the patient had a high-risk exposure, I certainly think that's possible. If the patient had no high-risk exposure and just has new right upper quadrant pain, I don't know that I would be convinced that they have COVID. I think testing in that situation makes sense. That's a tough call.
Yeah, I would agree. Like I mentioned, only about a quarter to 30% of people have elevated liver enzymes. So even though it's normal, that doesn't necessarily exclude it. And the same can be said about GI symptoms too. I think with a fever and the rise of community spread, I think it's definitely worth ruling out as you are. But in terms of whether it be positive, I think it's going to be a coin flip. I don't want to hedge. I don't want to bet anything right now.
Okay, so there's some follow-up, I think, from the initial poster of that question. So he had some food deliveries and he's worn masks. Okay, so that's interesting kind of feedback. So I didn't put this in the slides, but that's a common question that comes up is, getting takeout food or getting food delivery considered a high risk kind of thing. Again, data on this is very limited. Our current kind of opinion and consensus is probably not. When you're getting either food delivery or takeout, particularly if we're wearing a mask, I think the risk would be pretty low. I don't think that in and of itself would make me terribly concerned. It does not look like the virus should be spread through food. So we don't think that that's a real significant mode of transmission. There is concern about the packaging, like the cardboard box or container, the paper bag, et cetera, plastic bag. The virus has been reported to be, survive on those surfaces. So if you're really concerned, you could, take your food out of the container, serve it, and then wash your hands. And then the risk of you actually ingesting any virus from the containers that it came in would be very, very low. In general, we think takeout delivery, food should be a very, very low risk sort of situation. And it does not seem like that is a high risk type of thing for COVID-19, especially if you're wearing a mask. Like if you go and get takeout and you wear a mask so that the person doesn't breathe on you, I think the actual food transmission is very, very unlikely.